Dacryocystorynostomy or DCR has never been the preferred treatment option for children and is often the last resort when other treatment modalities have failed. And yet, in patients with complex congenital nasolacrimal duct obstruction, DCR is the only choice following a variety of failed surgical interventions. We present here a safe and effective alternative to DCR. We use dual endoscopic guided probing to save children from an avoidable DCR in complex congenital nasolacrimal duct obstruction or CNLDO. To our knowledge, this is being performed for the first time in India. Our patient, a 26 months old girl, presented to us when her parents noticed watering and discharge from her left eye from birth. She had had a prior consultation elsewhere where the child underwent left syringing and probing under general anesthesia. During that procedure, it was noted that even the smallest lacrimal probe could not be passed through the nasolacrimal duct. And on syringing, complete regurgitation of fluid through the opposite punctum was observed pre and post probing. The finding of absolute bony block was made and the child was advised DCR and referred to us. When she presented to us, her lacrimal drainage system examination revealed presence of watering, discharge and regurgitation. Based on the history and clinical examination, left complex congenital nasolacrimal duct obstruction status post failed probing was diagnosed. As we know, around 5 weeks of gestation, an ectodermal invagination forms between the lateral nasal process and maxillary process. Later, proliferation of the solid cord of ectoderm occurs laterally towards the eyelid and inferiorly towards the inferior turbinate. At 7 months, canalization is nearly complete with only the puncta and valve of Hasner remaining imperforate. As the lowest portion of the nasolacrimal duct is the last to canalize, the imperforate valve of Hasner commonly causes congenital nasolacrimal duct obstruction, although other reasons include proximal nasolacrimal duct strictures, patchy stenosis, diffuse stenosis, and bony nasolacrimal duct dysplasia. The conventional treatment options for treatment of CNLDO can be non-surgical or surgical. Non-surgical treatment is essentially sac massage. The surgical treatment options in the order of preference are probing, balloon catheter dilatation, and primary intubation. If all these procedures fail, then dacryocystorynostomy may be considered. There are several reasons for the failure of probing, such as probe not piercing the membrane, impacted inferior turbinate, probe remaining submucosal in lateral wall, creation of false passage, injury to canaliculus or nasolacrimal duct mucosa, extensive initial pathology, or functional epiphora. We planned repeat syringing and probing for the child under dual endoscopic guidance. We used a 0.6 mm dacryoendoscope and a 2.7 mm nasal endoscope for the procedure. This is the view of the lacrimal drainage system in a normal patient. We can see the canaliculus with a whitish mucosal lining. As we progress, the lumen becomes narrow and is narrowest at the junction of common canaliculus with the lacrimal sac. As we enter the increased space offered by the sac, we find the illumination is insufficient. On increasing the illumination, we can appreciate the mucosal color change from whitish in the canaliculus to pinkish in the lacrimal sac. Similarly, on entering the relatively narrow nasolacrimal duct, we have to decrease the illumination to see the structures there. Here we can clearly see the reddish mucosa with the mucosal folds at the inferior end of the nasolacrimal duct. In this patient, when we entered the nasolacrimal duct, instead of the patent cavity with reddish mucosa, we could see chunks of whitish fibrous tissues totally blocking the duct lumen. Probing was done to pierce through these fibrous chunks of tissue. On nasal endoscopy, impaction of the inferior turbinate was observed, which was then medialized. We can now see the probe passing freely as medialization of the inferior turbinate increased the available space, facilitating the free movement of the probe from the nasolacrimal duct into the nasal cavity. On re-entering the nasolacrimal duct with the dacryoendoscope, we could see the duct lumen with residual fibrous chunks at the periphery. A retrograde examination from the duct towards the canaliculus helped us to rule out any associated anomaly or damage to normal structures while performing the procedure. Primary intubation was done with Crawford intubation tube. Thus, in this patient, the entire surgical procedure included syringing and probing under dual endoscopic guidance, inferior turbinate medialization followed by primary intubation with nasal endoscopic guidance under general anesthesia. On postoperative day 1, the patient was doing well and was discharged on topical antibiotic steroid combination in a tapering manner along with a nasal decongestant. The intubation was removed 3 months later and the lacrimal passage was found to be freely patent. Based on this particular case management, we may conclude that multimodal treatment under dual endoscopic guidance addresses the main etiological factors and offers an effective way to manage complex congenital nasolacrimal duct obstruction. Thus, it is a promising alternative to pediatric DCR.